Welcome back to Midnight Med. This video is on anticoagulants. We're going to overview the main types of anticoagulants and look at why you may prescribe a patient one kind of anticoagulant over another. We're going to look at why you may absolutely not be allowed to prescribe one group to a patient and then evaluate it. So we're going to look at advantages, side effects, and if the side effects can be problematic, how to monitor it to make sure the side effects are not being worse than the possible benefit. So the first group are factor Xa inhibitors, for example, apixaban. Now these are probably the most common type of anticoagulation that you can give. Usually give it if the patient is stable and has no contraindications. For example, renal insufficiency or active cancer. The advantages are that it's good, it needs less monitoring, and it has a low bleeding risk. Remember, whenever you anticoagulate, you are thinning the blood, so there's always going to be some bleeding risk, but it's important to make sure it's not too high. Main side effects include deranged liver function tests, so it is hepatotoxic. You can end up with low platelets, and you can have nausea. Monitoring, those side effects are not too bad. You don't need to do anything regularly. But remember, contraindication is renal insufficiency, so it is worthwhile checking that the patient does not develop poor kidney function. Another important one is warfarin. So these are vitamin K antagonists. Indications include renal insufficiency. So you can think about normally you want to give a factor Xa inhibitor. If you can't, maybe warfarin's a good option. It can also be used in antiphospholipid syndrome, so it's common with patients with lupus. Contraindications included being teratogenic, so not in pregnancy, as well as bleeding diathesis. So there's a slightly higher risk of bleeding issues than factor Xa. So if they have an underlying bleeding problem, the patient shouldn't have warfarin. Advantages, however, are that it is reversible. So it is a vitamin K antagonist. You give vitamin K, you can more or less reverse it. It's not immediate, but it will be reversed. Side effects include skin necrosis, and it is hepatotoxic. Monitoring includes INR, so you're looking at the extrinsic pathway of the coagulation cascade, which we all love memorizing, but we won't go through here. And generally, you're targeting an INR of 2.5. Now, this will be different based on the patient factors, based on the specific indication for the warfarin. And remember, you can reverse it. For example, if you're going to surgery and the INR is too high, they need emergency surgery, maybe they have a acute bleed, you can give vitamin K to reverse it if that INR is out of where it should be. Considerations: warfarin, funnily enough, is initially a procoagulant, so you increase your risk of forming clots for the first 5 days to a week, and this is because it inhibits protein C and S. And that is why you need to give another anticoagulant, for example, low molecular weight heparin, which we will talk about, to avoid that initial risk of increased clots. Warfarin infamously has a number of drug interactions because it is metabolized by the CYP450 enzyme, so inhibitors and inducers of the CYP450 will be affected. Some common examples include phenytoin, carbamazepine, your depression drugs, selective serotonin reuptake inhibitors, as well as erythromycin, a common antibiotic. And the first two drugs are seizure medications. Low molecular weight heparin you can use if the patient is pregnant, if it's active cancer. Remember, if a patient has cancer, the increased risk of forming clots, and as well for bridging in warfarin. Monitoring renal function. It's not a complex drug. Unfractionated heparins, or commonly known as just heparin, you have side effects of osteoporosis, hyperkalemia, heparin-induced thrombocytopenia, and liver function derangements. Heparin is an antithrombin 3 potentiator. Monitoring, you're looking at the intrinsic pathway and coagulation cascade, opposed to warfarin, which is extrinsic, remember. So because it's intrinsic, you're monitoring APTT, and at the start, do it every 4 to 6 hours because you want to titrate your levels. First blood count, specifically platelets, because of the thrombocytopenia, every 2 to 3 days from days 5 to 14. That's what we do here, but make sure you check it for your local guidelines. Advantages usually can be given as an infusion, so you can stop it. You stop the infusion, it's done. However, if you're not giving it as an infusion reversal, you can do with protamine sulfate. The final class we're going to talk about are direct thrombin inhibitors, for example, the dabigatran. These are also sometimes put in the same DOAC-NOAC vibe as factor Xa inhibitors, but they're different. But they do have the same indications and contraindications. Side effects, you're thinking gastrointestinal stuff, so GI bleeding, for example, ulcers, as well as dyspepsia. Monitoring, like factor Xa inhibitors, you don't have to do anything regularly, which is an advantage, but you have to check your kidney function. Dabigatran and direct thrombin inhibitors generally are also initially procoagulant, so you need to do bridging low molecular weight heparin for the first 5 days. But interestingly, for direct thrombin inhibitors, you don't give it at the same time, you give it 5 days after. With warfarin, you can give it at the same time. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.